Happy Monday, everyone. And once again, thank you for joining us today for the 2020-2022 State Health Improvement Plan Mental Health and Addiction Work Team meeting. This is Erigina Clay, Health Policy Analyst at the Health Policy Institute of Ohio. Just a few housekeeping rules before we get started today. For now, everyone is in listen-only mode. We definitely want this to be an interactive meeting, so if you have any questions, please be sure to type those into the question box that you see here. If you would like to raise your hand, we will unmute you. If you've muted yourself, then you have to unmute yourself for everyone else to hear your comments. Once again, make sure that you have entered your audio pin. It's located to the right side of your screen. You will need to log in to the webinar first before calling in order to get your pin. The slides and other meeting materials, including the recording of today's webinar, are posted here on HPIO Shawship webpage, so you can get that information later. And here is the organizational chart of all of the stakeholders involved in the SHIP. As you see, the Mental Health and Addiction Work Team is located at the foundation to the far left, and it's outlined in red. So you guys are able to see yourselves. Now I would like to take a moment and introduce my colleagues at HPIO joining us today. In the room, we have Amy Bush-Stevens, Haley Aka, and Alana Clark-Kurt. You should also be able to see the attendee list for today's webinar participants on your screen. In a moment, Amy will provide some more background information on the SHIP process and purpose and list of all outcomes and indicators for mental health and addiction. Then we're going to move into some discussion to set overall targets, identify priority populations, and set priority population targets. We'll conclude today's meeting with next steps for the project. Our objective for today's meeting is for HPIO and ODH to have the guidance needed to finalize the overall targets, priority populations, and priority population targets for mental health and addiction. No final decisions will be made on the call today, but your input will guide the final decisions that are made over the next few weeks. And now I'll hand it over to Amy, who will review the SHIP process and purpose.
Good morning, everyone. This is Amy at HPIO. Looks like we have a really good group on the call today. About 24 people have joined so far. So that's fantastic. I'm going to start with a reminder about why we're here and where we're going. In the overall SHIP process, this is our timeline. We will be delivering the final SHIP to ODH by the end of September. And we are currently kind of in the middle here in July, which is the target setting phase of the work. And later this month and into August, we'll be looking at strategies to include in the SHIP. And throughout this process, there is also a parallel assessment happening for the maternal and child health and maternal and infant and early childhood home visiting, or MICV assessment that's being done in coordination with the overall SHAW and SHIP. The purpose of the SHIP is to get us all rowing in the same direction to improve population health in Ohio, and that's why it's important for us to be concise and prioritize toward common goals. We know that prioritizing is challenging work, but it's necessary if we're going to be strategic about working together to improve outcomes. The SHIP is a tool to align state agencies, and we have a steering committee that is made up of the directors or designees from these agencies. And then also it's about improving alignment and collaboration at the local level with many different types of local partners. The SHIP is our opportunity to track progress over time, and this chart looks at Ohio's progress on the objectives that were in the 2017-2019 SHIP. And here, green indicates things are improving, yellow means little or no detectable change, and red means things are getting worse. Clearly, we have a lot of work to do. And the goal for the SHIP, really the vision for what we're doing, is that we will get to green. So it's all about getting to improvement. The goal is to ensure that all Ohioans have the opportunity to achieve their full health potential. So this means eliminating disparities and inequities and achieving health equity. Now we'll take a look at the framework for the SHIP that's guiding our overall work. This is a new version, the latest version of the SHIP framework. And if you've been engaged in the process throughout over the past few months, you'll know that this is a revised framework, slightly different from the one that was used in the last SHIP. We flipped the SHIP, meaning that we put an emphasis on the blue things on the left, particularly those community conditions and other factors, also known as social determinants of health. We've simplified the language with those questions across the top, which are intended for audiences beyond public health, and then we've elevated equity in this framework. Here's where mental health and addiction fits in with this overall framework in the red box here. These are the main components of the SHIP. We have our SMART objectives, priority populations, those are groups with worse health outcomes, evidence-based strategies, and strategies to reduce disparities, inequities, racism, and discrimination. Today, we're focusing here on the SMART objectives and priority populations, and then in August, we'll be getting into the things on the right. And here's a reminder of our objective today. Okay, now I want to do a quick recap of where we are and how we got here specifically for mental health and addiction. To remind you of the prioritization process, we started this work back in October 2018 with the regional forums where we gathered stakeholder input. Then we also looked at secondary data in the state health assessment, and ODH is going to be releasing the SHA very soon. Then we shared all of this information with the steering committee and the advisory committee. We had a meeting on June 4th of the advisory committee where we had a small group discussion about access to care, and I think some of the folks on the call today were part of that conversation. And then we followed that up with an online prioritization survey, and all of the feedback that we've gathered so far through all of these different methods has helped us to narrow down to the set of outcomes and indicators that we're going to be talking about today. Now we want to have a quick poll question to get a sense of how many of you were able to participate in the small group discussion that we had previously about mental health and addiction in June. So did you participate in the June 4th SHA-SHIP Advisory Committee meeting? So maybe you were there and you participated in the mental health and addiction small group discussion, or were you there but participated in a different group? No, but you were able to review the materials online, or not at all. Please take a minute to let us know if you participated. And the reason that we're asking about this is that what we're talking about today really builds upon all of this work. So if you are new to the work team, we welcome you. We are happy to add people as we go along in the process, but we encourage you, if you're new, to review the materials posted on the HPIO SHA-SHIP page to get that background. Okay, Alana's gonna pull up the poll results here. Okay, so a little more than a quarter of you were participated in that small group discussion. That's great. And then about a third of you are new to the process. All right, moving us along to the outcomes. These are the desired outcomes that we have prioritized for mental health and addiction, and this will look pretty similar to what we included in the last SHIP. These were the criteria that we used as we were reviewing and updating the outcomes and indicators for mental health and addiction, and this is what it looks like looking at the detail for all of the indicators. And Haley's going to get us into more detail with that data in a little bit. But I'm going to start with some background information about target setting and priority populations. So I'm sure many on the call are familiar with SMART objectives. This is an example from the last SHIP. This is what the SMART objectives looked like for mental health and addiction. So these were the overall objectives. We're going to be focusing today on the target part of the work, so that far right column. And then these were the priority populations for mental health and addiction from the last SHIP, and we're going to be talking about how to update those today. And this is what it looks like when we report out. So this is from the progress report on the last SHIP. Just one selection from that. So what the input that we're going to gather from all of you today will help us to update this and this for the next SHIP for mental health and addiction so that we can report on it like this in the future. Looking at components of a SMART objective, specific and measurable refers to the indicator and the source. And so we've made those decisions, which was the list of outcomes and indicators and sources that I just shared with you. Achievable and realistic refers to the target data value, and that's what we're going to be talking about today. And time-bound refers to specific years for the baseline and the target. We've set 2022 as the target for all objectives in the SHIP, and the baseline years will vary depending on the source. It's worth spending a bit more time talking about these two words here, achievable and realistic. We think it's also important to be aspirational, and there's kind of a tension here between being achievable and realistic versus being aspirational. As we set targets, we could look at it like this, so focusing more on being aspirational and really reaching for the stars as we set our goals in the SHIP. Or we could have a more incremental approach that was focused on being realistic. Or we could strike a balance between the two, where we would look at what seems achievable given current trends, but then reach a bit and really push ourselves to reach for a better outcome rather than just continuing the status quo. We want to pause here for a minute, and we would love to hear your thoughts on this tension or balance between being achievable and realistic. And let's see. The first question doesn't seem to be there, so I will just ask you. The first question is, what approach do you think we should take for setting the targets? Should we focus on being aspirational and really shooting for the stars? Should we be more realistic and focus on what's achievable? Or should we strike a balance? Please raise your hand and unmute yourself. We would love to hear in person from folks, or you can also use the question box. Okay, it looks like we have a hand raised from Lori. Go ahead.
Hi, this is Lori Chris. I think that setting realistic targets right now, given the data that you have shared and that our conditions are worsening or staying the same, I think could, and when I say that, I don't mean, under projecting what we're capable of in any sense, but being realistic so that we can experience some successes as a state and help build the momentum for more aspirational goals in the future is on my mind.
Okay, thank you. Other thoughts on aspirational versus realistic? Encourage you to raise your hand, and it looks like we have a question in the question box. A comment from Chip: strike a balance seems to be the best approach. Thank you, Chip. And we have a hand raised from Krista. Go ahead, Krista.
Hi. I would tend to agree. Maybe the balance is that maybe we look at our areas where we've actually not improved and be maybe a little bit more modest in what we aspire to, and maybe in some of those areas where we have seen some improvement since the last CHIP, maybe those are the areas where we could be a little bit further aspirational in some of the goals that we're setting.
So looking at what are the ones where we've gotten worse since the last CHIP versus what are the ones where there hasn't been much change, because none of them have really improved markedly. But we can certainly look at which ones have gotten worse versus which ones are kind of treading water. And we have a comment here from Tanya: a balance, but agree with the director, Chris, that we need to look towards achievable as well. And then from Jody: should this question include how we get the data? I'm wondering what the participation is in the YRBS across the state. And that's kind of a preview for the conversation that we're going to be having in a minute, looking specifically at those indicators that come from the Youth Risk Behavior Survey. And we actually don't have the data yet, but we're hopeful that we're going to have that data. And so we'll have to kind of have a placeholder for the YRBS ones for now. And then once we get the data, take a look at what those targets could be. Okay, I'm going to take us to another discussion question. And these two questions get at experiences you may have had setting targets. So what experiences have you had with setting targets in your organization or your community? And what are the lessons learned to inform the SHIP? And when setting SHIP targets, we already asked that question. All right, so if you have experience with setting targets, maybe in a local CHIP process or an implementation strategy process, or maybe with a state agency, let us know. Were you too ambitious or not ambitious enough? What were some positive or negative things that came from target setting? Okay, we do have another comment here from Director Chris. I agree with a balanced approach as possible to mix the aspirational and the achievable. If so, how will the public know which is which, and is that important? So that kind of gets at how we communicate what's in the SHIP and making sure that we're clear about that. So that's a really important consideration. Okay, and we encourage you to raise your hands, particularly if you have had experience at some point over the past few years with setting targets in your community, in your organization, in your agency. And did you maybe set a really ambitious target that you didn't meet or did meet? And how did that work for you? Okay, another comment here. It helps to balance between aspirational and realistic. People can get discouraged if targets are consistently missed based on my local experience. Okay. All right, I'm not seeing any more comments or hands raised, so we'll move to the next piece here, which is priority populations. Priority populations are groups that have worse health outcomes than the overall population. These are examples of priority populations that were included in the last SHIP. We looked at race, ethnicity, age, gender, income, education, disability status, and geography, depending on the data source. And some of the data sources don't provide any population breakouts. In a minute, Haley is going to share the data that we do have for mental health and addiction indicators so we can see what data are available and which groups are experiencing worse health outcomes. And then we'll ask for your input on those priority populations and those targets. Then we're going to talk about setting targets for priority populations, and there are a few different ways to think about how to do this. To illustrate two ways of setting priority populations, I'm going to use this apple tree metaphor that you may have seen for describing equality and equity. In these pictures, apples represent optimal health outcomes. The ground is representing the social, economic, and physical environment, and the crates are policies, programs, and other resources. In this first image, all three people have the same policies and programs, so those apple crates are the same size, but two of them can't reach the optimal outcomes because of where they're starting from. In the second one, the apple crates are tailored and targeted so that everyone achieves optimal health outcomes, and this is what equity looks like. Now we're going to use this picture to talk about two ways to set targets for priority populations. In the first approach here, universal targets, we would set the same target for everyone so that Apple would be at the same level. For example, the target for the Black infant mortality rate would be the same as the target for the overall Ohio infant mortality rate. This approach makes the case that we must eliminate disparities and inequities, and it's consistent with the goal of achieving health equity. But of course, to be effective, it needs to drive targeted allocation of resources and funding and power. So in other words, the targets are universal, but the strategies, those apple crates, need to be targeted and tailored with more resources directed towards groups who have the furthest to go to reach the apple. So the key things about the universal target approach are that the apples are the same, so the targets would be the same for all groups, but that means that the apple crates, the resources, need to be different to help us get to those targets. The second approach, the population varied targets approach, here the priority population targets would be set based on trends and baseline data and may therefore be different from the overall population targets. This approach is not as consistent with the goal of achieving equity, but it is seen as being more realistic. So this brings us back again to that question of balance or that tension between being achievable and realistic versus being aspirational. And again, we want to get your feedback on these two different approaches. And so what we want to know is which approach you think we should use in the SHIP. Should we use this population varied targets approach where we have different targets for different groups, or the universal target approach where we have the same target for all groups? And then, of course, that would need to be accompanied with intentional allocation of resources to get there. So I want to open it up again for questions, and looks like I've got a comment here. Oh, just hearkening back to the earlier conversation, Krista says, my experience is that a balanced approach maintains momentum and interest among partners. Okay, and then Chip, in reference to this question, the universal targets make sense, but we have we have to work on making sure the crates, the resources, need to be different for those disproportionately burdened. So we can't just have the apples be the same level, but then have the same level crates. All right, does anyone else want to weigh in on this? If so, we encourage you to raise your hand. Okay, another comment here from Tanya. Interventions and strategies should be population varied, but targets should at least aspire to be universal. Okay. Okay, we have a hand up. Oh, no. Okay, and then we have some other general questions here of things to consider. Just wondering what other suggestions you have for addressing equity in the target setting process, and what other issues we should be considering as we identify priority populations. So any other thoughts of things that we should be thinking about as we set targets, as we set the priority populations? We are going to get into the specifics of it for mental health and addiction here in a minute with Haley, but just want to open it up for any general thoughts. Or if any of you have had experiences with identifying priority populations, setting priority population targets in your community, any lessons learned there? All right. I'm not seeing any other questions, so I'm going to turn it over now to Haley, who's going to get us more specifically into the data.
Great, thanks, Amy. And thanks to all of you for being on the call today. We appreciate your time and expertise as we dig into the mental health and addiction specific information now. To review, our objective in this next part of the meeting is to gather guidance from you all in order to finalize the overall targets, priority populations, and targets for those priority populations for those mental health and addiction indicators. And again, no final decisions are being made on the call today. We're here to gather all of your feedback and information that will inform those final decisions as they're made in the next couple of weeks. As a reminder, these are the desired outcomes selected for the mental health and addiction priority. So we have the priorities to reduce depression, suicide deaths, youth drug use, and unintentional drug overdose death. And this is really similar to what we saw in the 2017 to 2019 SHIP. We landed on these indicators based on your feedback at our June 4th in-person meeting. We also took into consideration the results from the prioritization survey and some additional consultation we did with other subject matter experts. So here's how we're going to move forward in our conversation today. We'll review some specific data related to each of these indicators within the desired outcomes, and then we'll have a discussion about the factors to consider when we're setting targets for each of these indicators. So let's jump right into that and talk about our first outcome, which is to reduce depression. So in the SHIP, we will have two indicators to measure depression. You see both youth depression and adult depression here. Both of these are measuring the prevalence of major depressive episode within the last year. Also, both of these metrics come from the NOSDA. You'll see here that 14% of Ohio youth experienced a major depressive episode in that 2015 to 2016 data year. For adult depression, the prevalence was a little bit lower, with nearly 8% of Ohioans age 18 and up experiencing a major depressive episode in those same years. The online SHA shows us that the prevalence of major depressive episode for adults has stayed fairly consistent over the last several years, and that the Ohio rate is higher than the US rate overall. So with this sort of background in mind, and keeping in mind the conversation we just had about achievable versus aspirational targets, let's dive into our first discussion question, which is, what factors do you think are important to consider when setting targets for each of these indicators? So thinking about what targets we want to set for 2022, what measurement issues with the NUSDA, what federal, state, local policy changes, other trends, other issues going on in the environment, what will influence where we set those targets for depression? And so please go ahead, raise your hand. Love to hear your feedback on this. You're also welcome to type in the question box if for whatever reason that works better for you today. And I'm going to work on getting comfortable with silence. And I'll just sit here. We'd really love. Yes, Laura, I'm happy to repeat the question. So we would love to know what factors we should consider when setting the targets for youth depression and adult depression, major depressive episodes. So here, I'm holding my clicker. Here's that question. What factors are important to consider when setting these targets? Those factors might include things like measurement issues, policy changes, broader trends happening in the environment. What will influence the targets that we set for depression, both youth and adult? Hopefully that was helpful and it's spurring thoughts. Anything happening on the local level in terms of policy change related to, particularly youth depression? We see how high that rate is. Are there things happening on the local level that we need to keep in mind when we're setting the statewide target for 2022? Lori?
So looking at youth depression specifically,
Yeah.
I think it would be helpful to take a look at emerging research and pursue the answers to some questions such as, are we more assertively trying to identify this issue? So is there a measurement issue related to this? Are we paying attention to it more? Is there more likelihood to disclose? Those sorts of questions. And then also looking at some other factors that we're seeing emerge in the research, particularly around social media.
Sure.
And the impact on child and youth and young adult mental health.
Okay. So those things might mean that the rate is going to continue to increase, and that's something that we need to be aware of when setting a realistic, achievable target for 2022. Okay. All right, we're seeing some questions in the question box now. Okay. Chad says, youth depression is so complicated as the rate factors into other areas like home life, school life, bullying. Right, there's lots of different things that impact depression. Krista says, I wonder how measurement affects the reported target, right? With increased access to mental health providers and a decreased stigma, I can see both those affecting the rate we're seeing. So we could see positive trends in access mean that our rates of depression actually go up because of reporting, and that is an important thing to keep in mind. Hope asks, is there a way to determine if the rates are actually increasing or if there's less stigma related to treatment and reporting? So that's again, making that similar point, which is really important to keep in mind. Thanks, Hope. Kelly says, with the new student wellness and success funding in the state operating budget, schools will have access to funding specifically for mental health services, which is great sort of context to keep in mind as well. All right, Lori, we see your hand again.
Oh, I'm fine. The
Oh,
other
okay, great,
questions answered it.
wonderful.
Thanks.
Thanks, Lori. Okay. All right. Well, that's helpful. Anything else on depression and maybe adult depression before we're going to move into suicide next. So any final thoughts? Hope asks, have we considered the Oh Yes data with kids? Amy, will you say something about Oh Yes?
Oh yes, data is available for the local communities where they have schools that have used Oh yes, but we don't have good rolled up state level Oh yes data. So as we're setting targets and selecting indicators for the SHIP at the state level look, we can't use Oh Yes as the data source, but we can certainly have it on a list of options for local communities to use as a tool to assess their progress if they've selected mental health and addiction as a priority for their local plans. So thanks for mentioning that.
All right, so we are going to move forward now. And I'll just show you this. So for NUSDA data broken out at the state level, which is what we need to use for the SHIP, we cannot get data for subgroups for prevalence for major depressive episode. So for these indicators, there will not be priority populations, and that's just a limitation of the data source. So I wanted you to see that before we move on to talk about suicide. So again, both youth suicide and adult suicide will be tracked in the SHIP. You can see here the rate of suicide death per 100,000 population for each of these age groups listed. According to the data we have in the online SHA, suicide deaths for all ages have increased since 2008, and the Ohio rate has been higher than the US rate through that time. And when looking specifically at the trend for adolescent suicide, which is other data that we have in the online SHA, we see an even sharper increase in that trend for adolescent suicide. So we have the same question for these indicators that we had for the last. What factors are important to consider at the state and local level when we're thinking about what targets we want to set for these indicators for 2022? So I'll put that question up again. Measurement issues, policy change, broader trends. What will impact our target setting for youth and adult suicide? I'll put the data back up to sort of trigger some of those thoughts. Go ahead and raise your hands. We'll be happy to hear from you. So we still see, Lori, your hand up from even the last discussion. Did you have something that you wanted to add about this? Or is
Yeah,
that
I
just
just
a vestige?
one comment /
Okay,
question
great.
on the Oh
Perfect.
Yes data. If it's something, I think your comment was related to the fact that the data collection on it and therefore the statewide usability is not helpful for the SHIP SHA process. But if that's something that would be beneficial, think about that and certainly let us know so we can consider that in our planning and coordination at the state level moving forward. In terms of suicide deaths, I'm curious about how we might think about how other states create their targets for these for these data measurements. And Ohio is one of the few states that hasn't had a strategic plan around suicide, and that's being developed right now. So and we're looking at what other states do as well. So I'm curious maybe about what we might learn from other states and their measurement strategies.
All right, thanks, Lori. On your first point about the Oh Yes survey, there's definitely been an issue with having state level data since we haven't had an adequate sample size for the YRBS survey for the past few waves. Hopefully we're going to have that for the 2019 data, but I think going forward, anything that we can do to get to the twin goals of having really high quality state level data for things like the SHIP, but then also having good access for local communities to also be able to measure progress for their own plans. That's the dream of where we want to be, and I think we're not quite there. So we would love to be a part of any conversations to facilitate that in the future. And then on the suicide death targets, we have looked at other state health improvement plans for other states. And we have taken a look at some of the targets. I'm not remembering specifically for suicide, but we can certainly take a look at those. And I think we can also reference Healthy People 2020. That might be helpful too. And then that's great to hear that there is a strategic plan being developed for Ohio. Our goal certainly with the SHIP is always to align with any plans that are happening. And so it would make sense if we had the same target included in both. So we'll follow up to talk more about how we can make sure those things are connected. And I think Tony Coder is on the call as well. I don't know if he wants to add anything on that, but both things that we can follow up on.
Great, thanks. So I see a comment here from Tanya who says that there are some measurement issues around suicide and there's questions about whether suicides are always marked accurately. So that's something to keep in mind. And Jolene, we see your hand up. In order to unmute you, you'll need to add in your audio pin, and then we'd love to hear from you. So any other thoughts related to measurement or how to set what factors to consider for setting targets for suicide? All right, we see from Tony here, he says, his mic's not working, but the American Foundation for Suicide Prevention has a nice document to reduce suicide by 20% by 2025 nationally is the goal there. So that's good for us to know and something that we'll definitely want to consider as we're setting targets for our SHIP. Okay. Feel free. We'll continue to move on, but as things pop into your brain and other factors. Okay, Jolene says Jolene, we still don't see our ability to unmute you. So if you have feedback, would you please type it into the question box and I'd be happy to read it out. And then for anybody who is continuing to think of things as we move on, go ahead and throw your ideas into the question box. We'll be able to save all of those notes and take it with us, even if it doesn't get read out on the call today. It's feedback that we'll be able to take with us as we head into our next steps. So never hesitate to do that. Okay. So these are some of the breakouts that we see for our suicide data. And when the data is broken out by race and by sex, Males are the only subpopulation that have a suicide death rate that's at least 10% worse than the overall rate for both youth and adult. So those are the priority populations you see here, male, for both of those groups. We also added female to the youth suicide death as a priority population. Even though that rate is lower than the overall youth suicide rate, we are seeing a really troubling trend, an increase in that rate. And so the Department of Health wanted to make sure we definitely included that, and that was being measured over the next several years. So these are the priority populations as they stand for youth and adult suicide. Are there any comments about this or other populations that you all think should be considered? Does this seem right? Okay, Jolene typed in her question to the box. So she was wondering about the age groups and if we would define youth suicide up to age 24 years. This is typically how CDC looks at it and breaks out the 15 to 19-year-olds. Amy, is there anything you want to say about that?
Yeah, this is something that we talked about a little bit in the small group discussion at the June 4th meeting. And we did have different age category groups in the last SHIP, and the group was clear that they wanted to see a clear delineation between youth and adults. And I think we're mindful of a lot of school-based, thinking of middle school, high school, school-based interventions as specific to the youth suicide rate. But I would love to hear thoughts from other folks on the call if you think this age category cut makes sense, or if you think it would be meaningful to look at different age categories. So if anyone on the call has a thought on that, please let us know. Okay, we have a comment from Tony here. There is a large emphasis on veterans and suicide. However, I don't know if you want to go that granular. I think veteran status is potentially something that we can get. We'll look into that and see if that's data that we could pull. Thank you.
Okay, not seeing any other feedback on the priority populations, so let's move into our conversation about how to set targets for these priority populations. So very similar question to the one that you've seen multiple times before. What factors do you think are important to consider when setting targets for these priority populations? So right now we're talking about boys, girls, and men and suicide death. So are there any other considerations that we need to be thinking about as we're setting targets for those priority populations? Oh, Lori mentioned the growing trend among first responders and suicide, which is important and something to consider too. Thank you. Yes, and Krista says that veteran status is something that can be broken out. So we appreciate that, Krista. Thanks. Considerations for setting these targets. This is something we hear a lot about, particularly the youth suicide rate and its increase over the past couple of years. When we think about 2022, how achievable should this target be? How aspirational should it be? And what factors should we be considering when thinking about these targets? Would love to see some hands raised. Your voices are more interesting than hearing ours for the whole hour, so. Tanya says she agrees that when looking at age categories, using just 18 plus doesn't reflect the sharp differences in age groups in the young adult and older adults, so splitting out those younger adults who have higher rates versus the older adults. That's something to think about. Thanks, Tanya. Krista says, if we alter the age ranges, won't we lose the ability to show change over time? So there's already been some change in the age breakouts from the last ship to this ship, so we're already sort of in that territory. And so I think it's sort of open for discussion where we think the best place to draw those lines are. And hopefully we can carry that forward after this ship. That's a great consideration, though, and something we think a lot about. So thanks for that, Krista. Craig says, Healthy People 2020 uses a 10% reduction as a standard target for adolescent suicide. So we'll definitely look at Healthy People 2020 for all the indicators in the ship as a consideration, and so we appreciate that, Craig. How about state and local policy changes related to particularly youth suicide? I'm very sensitive to the attention that that's gotten recently. Are there things to consider as we're setting the target with what's happening at the local level, what schools are doing to implement? Are we feeling aspirational? Are we feeling maybe we need to be a little more conservative and achievable? What are we thinking about with the policy change environment around this? Okay, well, if anything comes to your mind, please feel free to type it in the question box and then we'll take it with us after the call. Okay, so the next objective, the next outcome that we'll be tracking in the ship is reduce youth drug use. And within youth drug use, we'll be measuring both youth alcohol use and youth marijuana use. Tobacco will be in another place, but we're measuring that too. The data source for both of these indicators is the YRBS. And we've decided, ODH has decided that the baseline data year for these indicators will be 2019. So at this point, we don't have that data yet. It is pending. We believe that it will be available later this year. And so at this point, it's hard to have a conversation around how to set the targets and what the breakouts might be for these because the data is still pending. So this will be a little bit of a placeholder in the ship for now and something that we'll be able to revisit when that data is available. But we just wanted to make you aware of this and that these are the indicators that are within that reduce youth drug use priority. So the final thing that we'll discuss on the call today is unintentional drug overdose deaths. Oh, I'm so sorry, there's a question. Okay, Lori, do you have your hand raised? Let's unmute you and then we can.
Yeah, so because the youth data from YRBS includes middle schoolers as well as high schoolers.
Yeah.
And we know that vaping rates, so exposure to nicotine and the reduced amount of time it takes for someone to become dependent on that is a potentially predictive factor in substance use disorders more broadly. Would the group consider adding nicotine use and I don't know if the YRBS included vaping specifically as a question, but would that be something that we could consider as a measure as well?
Yeah, so YRBS was done with the Ohio Youth Tobacco Survey, so it does have a question on vaping and as well as several other tobacco products. And so just to kind of back up to a conversation that we had with the health behaviors work team on a call a few weeks ago, we talked about should youth nicotine and tobacco use be included in the mental health and addiction bucket, or should it be included in the health behaviors bucket with the other tobacco measures? And so we had a conversation about that. There's kind of pros and cons to both. the group came to consensus to put it in the health behaviors category. And so, and then we had a conversation about, should it be just vaping? So should it be just e-cigarette, Juul, use, or should it be all tobacco use combined, which is a measure that combines cigarettes and hookah and cigars and vaping and everything together. And what the group recommended was to do the all tobacco use, since that trends could change over time. So that's where we landed with how to address youth nicotine use. It's certainly been a big part of the conversation up to this point. So I'd love to hear if there are others. Well, your feedback too, Director Chris, on this question, and then if others on the call just have thoughts about where that landed. So again, we do have in the health behaviors section of the SHIP framework all tobacco use, which includes vaping, e-cigarettes, and other forms of tobacco products. And that is, that's from the youth, the YRBS survey as well.
Go ahead, Lori.
Yeah, so can you define what the health behaviors, and I'm going to have a follow-up to this, so after so please don't mute me after I ask this question. But can you define what the health behaviors focus is? I think of that in terms of quality of life, years of life lost, and vaping and nicotine exposure was something that we had made significant impact on, and nicotine exposure, and vaping has reversed that trajectory significantly in the past year to 2 years, particularly among younger children, preteens, teens. And so I don't think we should underestimate the impact that it has on potential substance use disorder later in life, and don't want to, from a policy standpoint, I think it's, the research shows that it's a relevant conversation for us to be having in relation to addiction and substance use disorders, not just in terms of other health consequences and years of lost life.
Yeah, absolutely. The health behaviors section of the framework has tobacco and nicotine use, physical activity, and nutrition. So those are the 3 areas. So, but I think that making that connection between particularly vaping and future drug use is obviously an important connection to make. Is there anyone else on the call who wants to weigh in on that, or and some of you may also be a part of the health behaviors group and have been in these conversations. For others of you, maybe you haven't heard this conversation, so we want to make sure we bring in as many voices as possible on where that should live, because it's obviously a really, really important thing that we don't want to get lost in the overall story of the SHIP. Okay, I'm not seeing any hands. All right, so Director Chris, would you then, your preference would be that we include youth e-cigarette use as an indicator in mental health and addiction rather than youth all tobacco use in health behaviors?
Is there a reason that we can't put it in both places and just track the same data and goals and show that it impacts both physical health more broadly and also substance use disorders more specifically?
We could definitely think about that. Yeah. Absolutely. Okay, I'm gonna turn it back to Haley.
Okay. If you have any additional thoughts about this or any of the other indicators we've looked at previously, please continue to throw them in the chat box. We know we're running a little over time, but we do think it's important to get to the, I'm just flipping right past, the drug overdose data as well. So we know what this trend has looked like over the past several years. We've seen really large increases. Ohio is significantly larger than the US in our drug overdose death rate. We are seeing some preliminary 2018 data that's suggesting our drug overdose death rate is starting to come down. It's still higher than the US overall. So still definitely something we need to be thinking about. Are there any sort of overall thoughts on how we should think about setting a target for drug overdose death for the population overall for 2022? Not seeing any. Yeah, go ahead and raise hands if you, maybe what I'll do is move on to the priority populations. And if you have a thought about the overall target factors, we can lump those into that conversation. But this is one where these are the targets. This is a measure that we had in the last SHIP. These are the priority populations that we had in the last SHIP. And you'll see how specific they are. So each of the priority populations is a mix of 3 different sort of factors. We have race, sex, and age lumped together to create our priority populations. We saw increase in each of these populations in the drug overdose death rate from 2015 to 2017. And I specifically want to draw your attention to that first group, white males aged 25 to 44, and the last group, Black males age 55 to 64. You see how high both of those were in 2017, and that the older Black men, their rate even came a little bit higher than the younger white male rate, which has typically been the highest for drug overdose death in the last several years. So, so these are the priority populations as they existed in the last SHIP. Do we think that these are the appropriate priority populations? Is there some other priority population that should be considered? And just in general, as specific as these populations are, is that the right way to be thinking about the priorities for drug overdose death? Or should they be a little more general, maybe Black Ohioans or white males or men of a certain age? So are there different sorts of populations that we can consider that maybe aren't as specific? So I'd love to hear what folks on the call think about those sorts of options. So go ahead and raise your hand and let us know what you think the best sorts of priority populations might be for this indicator. Okay, so Director Chris commented that she agrees with the priority populations as presented here, and that we shouldn't generalize because of age and gender, because age and gender matter in public policy and public health efforts. Do you want to raise your hand and say a little bit more about what you mean by that, Director?
Yeah, I like having it broken down by age group has been something we've been tracking for years. So I think that reversing tack on that would, I don't think it would be helpful to us in looking at longitudinally the relevance of this data. And having the gender broken out is something that has really allowed us to see at the state level what's happening, particularly among older African American males, which was an unexpected change between the years shown, and allows us to be more specific in our public health efforts and in really calling out what strategies we might need to consider differently in public policy too. So I think that these categories make sense, and continuing with them is the right trend.
Okay. All right. Thank you.
Yeah, I'd also say that while we do see the numbers improving, and we won't have those numbers um, finalized for a while yet, I think that 1 year of improvement is something to be encouraged by, but it's not a
Right.
trend. And so I
Right.
just caution us from moving um, too far in a direction based on that information.
Right. Right. Absolutely agree. Do folks think that because of the beginning of some momentum towards reducing our overdose death rate in the state, that our target might be we might make it a little more aspirational? How do people feel about where the target should rest based on the trends we're seeing in overdose death?
And this is where I think having it age and gender and race specific
Mm-hmm.
might be helpful. I think aspirational with some of the trends we're seeing would be a challenge, but with other populations, not so much. So this might be a place for balance based on the drilled down information available to us.
Okay, yeah. Okay, so Hope says that she finds it confusing that the age ranges vary so much. Hope, can you say a little bit more about that? We can wait for you to type that in since you're using that mode of communication. Oh. Hope, we see that your hand is raised.
Yeah, I'm just sitting here with a couple of other folks at DODD, and we were looking at it, and actually it took us a little while to even notice that that the ranges were different for the different groups, and I think it might be difficult at the local level to, if you're trying to track things, to keep straight. Oh well, this one is 25 to 44, and this one's 45 to 64. And even, I mean, I'm assuming these were selected based upon some sort of data outlier ranges. I wasn't in the previous meetings, but I think it would just maybe be difficult for the general population and for people that are specifically trying to track it to keep up with which ages was it for this group, that kind of thing.
Okay. All right, that's helpful feedback, and we can think maybe that lends itself more towards the messaging and the clarity around labeling the categories and all of that to make sure that it's very clear what we're talking about in each of these groups. So that's helpful feedback. Okay, let's go ahead and throw our one and only data poll of this call. Let's get some clear feedback on how you think the priority population should be measured. So what type of priority population should be selected? Should we maintain the groups as they were in the 2017 to 2019 SHIP, so those groups as you were seeing them on the screen? Or do you think it's more important to just have priority populations based on race or age or gender? So go ahead and let us know what you think would be the best way to approach priority populations for this. The other option is to not have a priority population for this indicator and to measure just overall drug overdose death for the state. So a few people have voted. Go ahead, we'd like to see participation from everyone. I'm seeing some consensus in the votes as they are now, so I want to make sure we capture everyone to make sure there aren't outliers. Okay, I think, yeah, we can go ahead and throw that. And we're seeing some consensus that they should maintain the same. So that's really great feedback, and we appreciate you sharing that with us. Okay, we can hide that. I think at this point we might end the call. We're a little bit over, and people may be hungry and ready for lunch. So we so appreciate the time that you spent digging into the data with us and thinking about how to best set these targets so that we strike that balance of achievable and aspirational. If you have additional thoughts about factors that should be considered as we're doing this work, please email me or email Amy and let us know what other plans might exist out there, different policies that you're hearing about that might impact these things. We really want to make sure that we're taking all the feedback that you have and incorporating that. And at this point, I'm going to turn it back over to Erigina, who will close us out.
All right, thank you so much, Haley. So moving forward, HPIO will send out a link to the final SMART objectives list with targets by August. And here are the dates and times of the next strategy selection meetings. We ask that you attend the meeting that best aligns with your skills, expertise, and entrance, and also availability. As you see here, the strategy selection meetings are organized by health factor instead of health outcome priority topic. So this means that at the access, for example, at the Access to Cure strategy meeting on July 30th, we will be prioritizing strategies that will improve access outcomes as well as access related strategies to improve the shift priority outcomes for mental health and addiction, chronic disease, and maternal and infant health. For more guidance on deciding what meeting you would like to select, you can always visit HPIO Shawship webpage. As a reminder, the strategy selection meetings are going to focus on, of course, strategy selection, and we're going to have small group discussions. So in-person attendance is preferred. There won't be a call-in option for this meeting or for these sets of meetings. The agenda for the strategy selection meeting will be posted on the HPIO Shawship webpage, and you can also get directions to HPIO and parking information. We thank you for your time and attention today, and hope you all have a great lunch and afternoon. Thank you.